Good morning, everybody, and warm welcome to the second EASL press conference on NAFLD. Plan is I'll have a brief introductory here around the field, and then we will have a representative of the individual abstracts presenting them, and afterwards questions. And after that, if you have requests for individual interviews, then please just reach out. So my name is Aleksander Krag. I'm the Vice Secretary General of EASL. EASL is the European Association for the Study of the Liver. We are the one hosting this event. We're really proud of having 7,000 delegates and see all the activity here, and also that we have really strong scientific breakthroughs. And a warm welcome to all you media representatives. We also have representatives online, and it will be available online also. So I think there are many really exciting things, but here we really picked some of the, I think, top content of the conference. And I think we also need to rework the way we think liver. So liver is often described as the silent disease, but I think this is an opportunity to really put it in the light, and that's where I think the media is really important. So I think the facts speaks for themselves. Liver diseases are on the rise, and the fastest growing cause of death in UK compared to other killers, sort of heart disease and cancer, where we have actually implemented better measures. And I think of particular concern, which we also published in the East Atlantic Constitution, this is the main, one of the second leading cause of lost life years in the younger, between 35 and 49 years. So this is something that really circled back to the real burden on society. And now today, particularly, we focus on NAFLD, the fatty liver, which is the fastest growing causes of liver cancer, HCC, both in and the leading cause in US, France, US. And then let's say NAFLD is fat in the liver, then we have the more aggressive type that's called NASH, and that's what we will focus on here. And if we drill it down to the cost, so if we just leave it as it, then the predicted annual cost of handling this fatty liver disease in euros is estimated to be 35 billion euros in direct healthcare costs. And if then add the associated cost, it amounts to 200 billion every year. So that's why we need to do something now. So the global burden of NAFLD is so high that we are going to need, I think, both all the prevention and treatment tools at our disposal. So obviously, prevention through change in lifestyle, diet is, could call it a no-brainer, something we can basically do and will cost little for the government. And for the sake of our young generation, I think we really need to take this serious. Still, we have this obesity epidemic. We can come back to that. But measures, I think, at a political level we can very easily implement is, for instance, banning advertising for junk food towards kids. But also educating young people and the families to have a more healthier style. People need reassuring about why good diet is so important in the long term and really promote their health. But we also need, and the really important one thing is what we can do ourselves, what we do politically, but it's clear we cannot just have people lose their weight. We also need good intervention to drugs to add on to this. And that's why it's exciting that we here host and have some late-stage trials that really are likely soon to change the way we do business with the patients, and these will enter the market. And before I introduce my esteemed colleagues here, let me just run through a little housekeeping. So it's being broadcasted live on the conference platform and will be recorded and also be available on the EASL YouTube afterwards and open. So we basically have this very transparent way of working. And for all of you, really happy to see you all, but please, when you ask a question, just let us know which media outlet you are from, and make brief, sharp, very good questions, and we are most happy to answer them. And of course, to you online, you are also most welcome to ask questions. So please use the click there, join the discussion, and a similar way also where you're from, and have the good questions. So now over to my esteemed colleagues here. The first speaker is the well-known Zobair Younossi, who is chairman of the Department of Medicine, the Center for Liver Disease at Beatty and Beatty Center for Integrated Research in the United States. And you also have a talk today at the general session. So could you please let us know what's there?
Sure, absolutely. Well, thank you very much for allowing me to participate in this session. As you just heard, NAFLD, and in fact, there is an abstract poster today, it was yesterday, that showed that with meta-analysis, that about a third of global population have fatty liver disease. 30% is the prevalence of NAFLD. That actually was published here yesterday. There's a second, actually, abstract that's being presented here that shows that in the United States, looking at the transplant database, currently NASH is the second indication for liver transplantation. And in fact, in HCC, it's becoming almost number one indication for liver cancer, indication for liver transplantation for the United States. So the burden is very high. The conundrum is that despite this very high burden, awareness about this disease at the population level, general population level, at the healthcare provider level, especially primary care, and especially in the policy maker level is very, very low. In fact, when you look at WHO, they really are not mentioning NAFLD as an important non-communicable disease, and that has to change. Well, the study that we are presenting today uses the global burden of disease data set or study. This is a collaboration of about 7,000 investigators from about 150 different countries across the globe, and they're looking at incidence, prevalence, mortality, and DALYs, which is disability adjusted life years, which is a sort of an estimate of morbidity and real burden. This is kept at the University of Washington, and we've actually analyzed and published from this before. What we've done in this study currently is to look between 2009 and 2019 changes in the burden of 4 important diseases, liver diseases. That's NAFLD, alcoholic liver disease, hepatitis B and C. The bottom line is that there are about 2 billion cases of liver disease, chronic liver disease in the world. And when you look over time, there is actually an increase in all kinds of liver diseases, especially when you look at what's called annual percentage change. So on an annual basis, the largest increase in mortality from liver cancer or cirrhosis, chronic liver disease cirrhosis, the highest is related to NAFLD. In fact, when you look at different regions of the world, GBD has 21 different regions, 7 super regions. In most regions of the world, there is actually an increase in NAFLD. In contrast, if you look at hepatitis B, because we were so good at vaccinating people, there is a decrease in the burden of hepatitis B-related mortality from liver disease, but NAFLD is going up. If you look at NAFLD and where NAFLD is actually primarily exploding is in Middle East, North Africa, and East Asia. So there is a huge, and this is not only in this area, of course, there is a huge increases in the West as well as in South America. But the largest area with the increase and burden of both prevalence and mortality. Now, we knew that the prevalence is high in the Middle East, but now we're seeing that mortality is also high in the Middle East. So you're now connecting what was actually a study of meta-analysis, which is putting a lot of data together to ultimately outcomes data, which is mortality and DALYs. So the bottom line of this study is that the burden of this disease is going up. It's the disease that's actually probably going to be the most important liver disease in the next decade or so. On the other side of this coin is that awareness is low. We do have some non-invasive tests that are being developed, so we don't have to do liver biopsies to diagnose these patients, and that's coming. Currently, now there's not a lot of treatment, but there are some very good treatment that's being developed, and hopefully in the next year or so, we will have at least the initial sort of drugs that will be approved. But awareness and increasing awareness is going to be the number one important priority from my perspective, and that's what this study is actually putting the awareness sort of priority at the global level.
Thanks a lot, Zobair, for this, and our next speaker is Scott Harris from Altimmune, Gaithersburg, US, and you have some very exciting results, I think, from new drug that both affects weight and liver. So please.
Well, thank you for the opportunity to speak about our abstract. That's OS 124, which will be presented by Dr. Stephen Harrison of Pinnacle Research in the section of NAFLD therapy at 6:30 p.m. tomorrow evening. Dr. Harrison will describe the findings of Altimmune's 12-week placebo-controlled double-blind first-in-human clinical trial of Pemvidutide, a novel GLP-1 glucagon dual receptor agonist for the treatment of obesity and NASH, which was conducted in volunteers with obesity and overweight. Advances in the use of GLP-based compounds, and I should say very quickly that GIP is a natural gut hormone, for the treatment of obesity have resulted in reductions in body weight that were once only thought to be achievable with bariatric surgery. Recently, weight losses in the ranges of 15 to 22% were reported following 17 to 18 months of treatments in trials of semaglutide, which is known as Wegovy in the United States, and tirzepatide, which is known as Mounjaro. These are compounds that either activate GLP-1 receptors alone or GLP-1 in combination with another gut hormone, GIP, receptors together. Pemvidutide likewise activates GLP-1, but it combines GLP-1 with glucagon receptor agonism in the same molecule, a so-called dual receptor agonist. The rationale for combining GLP-1 and glucagon receptor agonisms is the observation that GLP-1 suppresses appetite while glucagon increases energy expenditure and fat burning, mimicking diet and exercise. Pemvidutide incorporates a 1-to-1 ratio of GLP-1 and glucagon activity that was shown in preclinical studies to be optimal for weight loss and glucose control. Now, in the phase 1 study that Dr. Harrison will present, 12 weeks of Pemvidutide at the 1.8 milligram dose resulted in greater than 10% body weight loss in that 12-week period. Very quick weight loss, very rapid, with all patients in that 12-week period achieving at least 5% weight loss, and more than half achieving in that 12-week period alone 10% weight loss. The speed of the weight loss was obviously rapid, but more importantly, the trajectory suggested that 20% or more could be achieved over the course of a 1-year clinical trial, perhaps even more. We also observed reductions in total cholesterol, LDL cholesterol, and triglycerides that were in the range of 25 to 40%, equivalent to the results achieved with statins and fibrates. In all subjects with steatosis, that is fatty liver, at baseline who received the 1.8 and 2.4 milligram doses, Pemvidutide reduced liver fat to below the limit of detection, a greater than 90% reduction. The magnitude of these effects have not been realized by other candidates that are in development. The pronounced impact on liver and serum lipids was expected based on the known effects of glucagon on lipid metabolism. Pemvidutide was also well tolerated without the use of dose titration, with no dropouts due to what we call adverse events. Pemvidutide incorporates a proprietary 18-carbon glycolipid, which means a carbonation of a carbohydrate and fat chain with surfactant properties like a detergent in lay terms, called the Uport domain, to achieve prolonged half-life in convenient weekly dosing. The Uport domain is also thought to result in a depot following subcutaneous injection, importantly, slowing the compound's appearance in the bloodstream with a lower peak concentration and also delayed time to peak concentration, which is believed to result in better tolerability and obviate the need for dose titration. And if you recall, the other compounds have to be titrated over a prolonged period of time, up to 5 and 6 months. This has led to these compounds utilizing these slow dose titration regimens to minimize gastrointestinal adverse events. Titration could be very problematic for primary care physicians who have little time for it in practice and patients who wish to achieve more rapid weight loss. The pharmacokinetic properties of pemvidutide, that is how fast it appears in the bloodstream, are predicted to result in better tolerability and eliminate, importantly, this need for dose titration, which slows the onset of the effects. The robust reductions in liver and serum lipids in our phase 1 study could set a new standard for the patients, for the treatment of patients with obesity and NASH, potentially translating to higher rates of NASH resolution and fibrosis improvement, which are the endpoints in the clinical trials for a drug being approved in NASH, and reductions, even more importantly, in cardiovascular risk. Pemvidutide is currently being evaluated for its effects in liver fat and body weight in a 12-week phase 1b clinical trial in subjects with fatty liver or NAFLD, defined as an MRI-PDFF, and that's an imaging study, fat content of 10% or greater at the start of the trial. Its weight loss potential in subjects with obesity is further being evaluated in the 48-week phase 2 momentum trial, which is being conducted at 25 sites in the United States. Thanks you for allowing me to present these findings.
Thanks a lot, Scott. These are indeed remarkable data, and coupled with what you just heard here with the rising burden of disease, this is, I think, very good news for the community and particularly for the patient in the long run. And the next speaker is Stephen Harrison, who's director at the Pinnacle Research in the US. So over to you, Stephen.
Thank you. So I think Professor Younossi set this up very nicely. Growing burden of disease, a pandemic of fatty liver throughout the world, but yet no approved FDA or EMA therapies to manage the disease. We've been trying to develop therapies for a long time in NASH, and many of them have failed to cross the finish line and become approved. But we've learned from those failures. We understand that NAFLD is not a single mechanism disease. It's pleiotropic, it's multifactorial. These patients are heterogeneous. They don't all present the same way. They may all have similar histopathologic findings in the form of steatosis, inflammation, ballooning, and fibrosis, but how they got there are all different, or many ways different. So when we think about mechanisms that target NASH, we ideally want mechanisms that work high up in the pathway, where we can hit the drivers of inflammation and fibrosis. And so that gets us to resmetirom, which is a thyroid hormone receptor beta agonist, liver-directed, once-daily therapy that's oral. And the data around this is growing. So we've published already a phase 2b trial showing that 36 weeks of resmetirom improved liver fat content significantly and also correlated with significant resolution of NASH. That led to the development of 2 large phase 3 programs. One of those, the Maestro NAFLD-1 program, is a non-invasive study looking predominantly at safety and tolerability, but also key secondary endpoints. That will be presented as a late breaker tomorrow. As part of that, there is an open-label, well-compensated cirrhotic arm looking at 80 milligrams. A few patients were dose titrated up to 100 milligrams based on PK and sex hormone binding globulin activation at week 2. The study was the same duration as the main Maestro NAFLD-1 trial. It's 52 weeks, and there were multiple exploratory endpoints to the trial. Among them, serum lipids, liver chemistry tests, some non-invasive markers of both liver fat and fibrosis, as also looking at liver volume, spleen volume, and then, of course, safety and lipids. So just taking you through the trial, 105 patients were enrolled in the first cohort, and that's the group we'll be talking about tomorrow. There were an additional 75 patients enrolled that we're not going to be talking about today that came later in what we call cohort 2. To get into the trial, you had to have a biopsy showing F4 disease or a biopsy showing F2-3 disease with clinical progression to cirrhosis, and a few people got in on non-invasive testing alone that were consistent with cirrhosis. When we look at the demographics of the patient population, it's very consistent with a well-compensated Child's Pew A 5 or 6 population. The mean age was 62.7 years, 64% were female, 70% were diabetic. The ASCVD risk score in this population was 16, mean ALT 40, mean AST 39, so essentially a ratio of around 1, consistent with advanced disease. But also note, these values in ALT and AST were more around the normal range. When we look at FIB4, 2.9 was the mean, Fibroscan KPA 24, and MRE around 5.7. So a definite cirrhotic population by any non-invasive test that you would measure. Now, when we look at some of the initial breakdown of how we evaluated this population, we can look at MRI-PDFF, and when we look at those with more than 8% liver fat content, and those with 5 to 8% liver fat content, and those with less than 5% liver fat content at baseline, what we see is some striking differences. As we go from a fatty liver in the setting of cirrhosis to a non-fatty liver in the setting of cirrhosis, we see that components of portal hypertension increase rather dramatically. Platelet counts drop, spleen volume increases, and MELD scores go up as well. So consistent with what we know about the loss of fat in a cirrhotic population is consistent with the development of more significant disease. Now, when we begin to look at some of the results, we'll first look at Fibroscan. Now, what we wanted to do here, noting that Fibroscan has a large coefficient of variation of up to 40% from patient within a patient, we set the threshold on a responder analysis at 25% improvement or 25% worsening. And 40% of the patients had a 25% or greater improvement in Fibroscan KPA over the 52-week time point. When we look at MR elastography, we looked at a 19% treatment effect or a delta, so an improvement or a worsening of 19%, because that appears to be the coefficient of variance somewhere around there. Looking at a number greater than that is linked to a change. So in that population, around 23% of patients had improvement of at least 19% by MR elastography, 11% had worsening. So a treatment effect delta there of about 12% or so. Now, moving on to MRI-PDFF, around 36% of patients all told had a 36% drop in PDFF in the population. And knowing that even in that population, some patients didn't have detectable fatty liver or had very low amounts of fatty liver, in total, the relative drop was 36%. Maybe interestingly and innovative and just as important is the change in liver volume. Overall, we saw a 20% change in liver volume in this cirrhotic population, which we thought was very, very interesting. When you look at spleen volume, we did a responder analysis because there's more variability in spleen volume over time. And there we set the threshold at 10%. About a third of our patients actually had a 10% change in spleen volume. And there was a strong correlation between change in liver volume and change in spleen volume. In fact, there was a strong inverse correlation with platelet count. As spleen volume decreased, platelet count increased. When we moved to liver chemistry test, there was a drop in ALT, AST, and gamma GT, particularly looking at those people who had a baseline value above 30. Atherogenic lipids improved with what we know to be true with this drug, what we know from the phase 2 trial. There was a 21% drop in LDL, a 22% drop in ApoB, and a 24% drop in triglyceride. And then essentially, just to summarize the safety, this drug was well tolerated and safe in this population of well-compensated Child's A patients. There was no difference in the severity of the different types of Child's Pew that we enrolled, those with fat in the liver, those with mild fat, and those with no fat. As I noted, there was a difference in portal hypertension measurements, non-invasive measurements, as you went from fatty liver into no fatty liver, but there was no difference in tolerability or safety or adverse events there. There was really no statistical difference in adverse events dating back to our data we presented on non-cirrhotic populations either. So in conclusion, what this study showed us in an exploratory analysis was that the drug was safe and well tolerated. There was significant improvements in liver fat content, in atherogenic lipids. There was positive improvements in ALT, AST, and GGT. There was very nice changes in liver volume. There was changes in MR elastography using responder analysis as well as Fibroscan. And so that's really the main take-home points from the trial.
Stephen, indeed, again, very interesting results. And I think now, yes, we got the burden. We got 2 very promising drug candidates. But again, given that this is a lifestyle disease, the final speaker is Camilla Dalby Hansen, looking into diet. So what can diet actually do in this disease? You've done during your PhD, I think, a very remarkable study. So over to you, Camilla.
Thank you. Hi, nice to meet you. So I want to tell you that if you have fat in the liver, you will benefit from eating fats. This is the conclusion to our research study. It's the first and most extensive research study done on this particular diet in patients with type 2 diabetes and fatty liver disease. So how did we do this? This particular diet is called the low-carb, high-fat diet. Many of you may know it. And we compared this diet to a classic diabetes diet, low in fats. 165 participants had to eat one of these diets for 6 months. And we performed many different investigations throughout the trial, one of them being liver biopsies. And to kind of elaborate more on the diets, the special thing about these diets was that we told participants, please do not lose weight. Eat until you're full. So the classic diabetes diet, many of us know it, it has been the go-to diet for decades, is low in fats and high in whole grain products, oats, potatoes, vegetables. The low-carb, high-fat diet, on the contrary, is very high in fats, very high. So it's primarily healthy fats, such as avocado, olive oil, nuts, and seeds, but also cheese, cream, high-fat dairy products. Also, this diet contained, of course, vegetables, but no bread, no potatoes, no rice, no pasta. So low in carbohydrates, below 20 energy percentage. So just to kind of give you an idea of how much fat they had to eat, it was above, the participants had an intake of above 60 energy percentage of fat. It's a lot. It corresponds to 1/4 liter of olive oil a day. Yes, so they really had to change their mindset a lot because it was difficult for them to start eating all these fats. We have been told for decades that it's not good. So it was difficult, but they did it. And what did we find? We found that the low-carb, high-fat diet was very good in improving diabetes control. It reduced the fat in the liver. And even though they were eating as much calories as they were used to, they were full, they lost 5.8% body weight. So we find this very interesting because some of the problems with diets today is that it's very difficult to sustain in the long term, right? So we thought this might be easier to comply with if you're full. So we hope that these results might give patients out there more options in the future, that they can kind of pick for themselves what fits into their lifestyle. And yeah, that's it. Thank you.
Thanks a lot, Camilla, and thank you for these data. I guess something that you don't need an FDA or EMA approval to implement. And thank you all for coming. And now it's open for question, and I think we'll even have 15 minutes for questions. So please come forward with questions.
Yeah, sure. Hi, my name is Becky McCall from Medscape. I have a question firstly for Dr. Younossi, please. I wonder if you could just clarify for me the contribution made by NAFLD and also by alcohol induced liver disease towards these outcomes, the liver cancer and the chronic liver disease. Because I understand most of it is still alcohol related, but the contribution of the NAFLD is just higher. Is that right? I'm just trying to understand the contributions of both.
So I think the area of overlap between alcohol and non-alcoholic liver disease is a very important area, because a lot of the patients who actually consume alcohol, excessive alcohol, they may also have diabetes and obesity, things that will drive non-alcoholic fatty liver disease. So I think for that reason, the number one actually cause of, say, indication for liver transplantation in the United States still is alcoholic liver disease, followed by non-alcoholic fatty liver disease. Now, and even in that context, when you look at alcoholic patients, probably the same prevalence, or even higher prevalence of metabolic abnormalities. So alcoholic liver disease will remain an important component of liver disease for years to come, because it's not only driven by alcohol, which has, by the way, gone up during the COVID, but also because it also has this contribution of the metabolic syndrome that actually, or metabolic component that drives that. But in terms of annual percentage change, for those who have absolute diagnostic categories by ICD-9, ICD-10, the APCs, the annual percentage change, was higher for NAFLD than for alcoholic liver disease in these global regions.
Thank you, Bud. Yeah, more. Yeah, please come forward.
Thank you. I don't want to hog it. I just want to ask Camilla, please. Hello. Basically, fascinating, first of all.
Yeah. Thank you.
So there are all sorts of fats here. You said the sort of cream, the bad fats, let's call them that, and then the good ones too. Did you say a quarter of a litre of olive oil? Is that what you said?
Yeah, it corresponds to that. Yeah, all
That's
the fat.
amazing.
Yeah.
How did the participants get on with that? How did they accept that? Because I'm thinking sustainability.
Yeah, okay.
You know, long term.
Yes. So of course, very good question. Thank you. So it was difficult for them primarily because they had so many feelings about fat from their whole lives, right? But we had like the most amazing clinical dietitian who followed all the patients and really supported them, and they kind of got into it. So we saw that many of them actually were surprisingly good. We had one participant, he was 75 years old. He was a farmer, and when he came to us, I thought, this is not gonna go. And he was like, he just did very, very good and got the same results, and people could really comply with it. But when I have said that, it is difficult to sustain on this diet in some situations for some people. Being social gatherings, and it is like that with special diets, right? So I don't think it's for everybody, but we can say that if people thrive with it, and some people really do, and it fits perfectly into their lives, go for it. Well, so it's important to emphasize that it's not just go out and eat all fat in the world. You really also have to focus on getting some of the good fats, and very importantly, not to both eat a lot of fat and a lot of carbohydrates. It's a dual, so it's important that you cut the carbs. This is what our results showed. But otherwise, so we really saw amazing results. LDL, called the bad cholesterol, was increasing marginally with 0.2 millimoles per liter, but combining this with the huge weight loss. The HbA1c, it's the diabetes control reduced with 9.5 millimoles per mole, and the blood pressure reduced in women. The insulin resistance got better. HDL, the good cholesterol, on the rise, and the triglycerides reduced. So all in all, very very good effects.
Thanks a lot. Yeah, please.
Thank you. Martina Lenzen-Schulte from the German Medical Journal. Mr. Harrison, phase 1 and phase 2b is very short, but have you any idea about concerning the mood of the participants? Because depression was one of the reasons for many drugs, amazing drugs, weight-lowering drugs, because they were stopped because the depression was a major problem.
Okay, so when we specifically look at resmetirom, we have not seen any change in depression or any psychiatric adverse events. Seems to be very well tolerated. Again, the major adverse event we've seen is early, transient, loose stools, and some nausea. So that's the main issue, and it tends to be early in the first 12 weeks and kind of dissipates, and does not lead to withdrawal rates of any significant concern.
Thank you very much. I think there were more questions here in the front.
Thank you. I'm Per Lundblad from the Swedish Gastroenterology Association's membership magazine. I'm very curious, brief question. Fat that we consume is very often together with sugar, like ice creams, chocolates, stuff like that. And you said they had to concentrate on healthy fat. Now, how would you rate chocolate ice creams?
Okay,
because it's a bit of both, isn't it? It's fat and it is sugar, which is
No. It's only fats. So yeah. So unfortunately, it's only the fats, not the sugar. So increase in the fats, but
yes. But if you eat lots of chocolates and ice creams, that sort of is not good.
No. Don't do that.
Brilliant. Thank you. I'll try to keep out of it.
Yeah. So it is, just to elaborate, it is really still, you need to think more about what you're eating. Yeah, for sure. And it's important to get some guidance, because it's not really obvious to everybody what this diet is about, right? So for sure, I would recommend to go to your doctor and get advice and get the follow-up checks on the way. Yeah.
Hi, Linda Gumlich, Springer Nature. Just a follow-up questions. Were there any vegetarians or vegans in your study?
Oh yeah, thank you.
And did they have to adapt to
Very
meat?
good, very good question. So we only had 2, so the protein consumption from meat was the same in both diets. So it wasn't a protein-enriched diet. They kept a normal level of protein. But so the thing with when you're a vegetarian, there can be some issues with getting all the all the fibers and some of the micronutrients. But with the help from our clinical dietitian, they managed. Yeah.
More question? Okay, I have a question here online. Do we know if high-fat, low-carb diet also shows any NASH-related benefit, less inflammation or fibrosis? And this is study enough for an official guideline recommendation. So if you just start off with if it also have any NASH-related benefits in terms of impacting inflammation or fibrosis.
Okay, thank you. So impact on fibrosis, no, we did not see any difference between groups, but we only did a 6-month study. So I don't know how it looks like in years to come. But on inflammation, we saw an improvement. So inflammation decreased. And of course, as I told you, the fat decreased. So on the NAS score, we saw that 70% in eating the low-carb, high-fat diet improved the NAS score compared to 48% in the other group eating the classic diabetes diet. And very interesting, actually, was that, so looking at the NAS score, only 1% in the low-carb, high-fat group worsened during the 6 months, compared to 23% in the classic diabetes diet. So that is also very
so there
important
is
to
something
emphasize.
there.
Yeah.
So for the rest of the question, which I think Morten, I'll not allow you to answer that because rather than we have super experts here. Yeah. So randomized trial, 165 patients with dual biopsy, these results, is that enough to be implemented or change recommendations in our guidelines? Maybe, Zobair, you want to start off here?
Well, I think it's an interesting study. There are a couple of things. I think the point that's being made here is that it's the sugar that's actually so dietary fat is not the same as fat in the liver. That's actually a misunderstanding of this disease. It has to do with sugar. That's number one. Number two, I'm always reluctant to take short-term study without long-term outcome, because what we need to know is that, okay, fat is going to improve, but our patient going to live longer, and that's going to require long-term data. And I think that's a good start. Until I have that kind of strong evidence that outcomes are going to change, or at least some surrogate of the outcome is going to change, then that's not too early to change guidelines.
So the surrogate of HB1AC that is significant, you still think in terms of the liver, it's probably, I don't know if you other have any input on this questions, otherwise we have more questions to come, but Stephen, what do you think?
Sure, I can provide input. So I think there's a lot of interesting things here, and I think we need to all commend you for your excellent study. It is a behemoth effort to do paired liver biopsies in a lifestyle modification trial, much less a drug trial. That's huge. What this tells me is that, look, foundationally, the way we manage patients doesn't change. It's lifestyle modification. It's eat less, run more. It's exercise and try to lose weight. That's going to happen whether we put a drug on a patient or not. And maybe in the long term, we may not have people on drug forever. We get them benefit, we show that their disease is improved, and we can offer them something that says you can maintain a healthier life by doing this. So I think it's very informative. Yes, it's a relatively small trial in the big scheme of things. The duration of the trial was relatively short. You improved the NAFLD activity score, although I don't know by how much. Did most people improve by 2 or more points? There was no change in fibrosis, but we wouldn't really expect a change in fibrosis in 24 weeks. I think it's provocative, and it gives us healthy information about how to help manage our patients from a lifestyle perspective that we didn't have prior to coming to this meeting. And I think for that reason, it's helpful.
Thanks a lot. So I don't have any burning questions. We have 2 final questions here. We're running a little bit out of time, but it's again, Camilla, there's clearly a lot of interest in this you can consider doing immediately and around diet. So we have here from Fatty Liver Alliance follow-up questions. Are dirty carbs like bacon also okay? Or is it better to eat more avocados and nuts? Or did you see a difference in effectiveness between healthy carbs and less healthy carbs? Okay. So first, bacon versus avocados and nuts.
Oh, I should have brought the clinical dietitian. So bacon is rich in also protein, but the fat from the bacon, as we know, is animal fat. It's the bad fat, the saturated fats. But what we saw was that when we looked at people who were eating a lot of saturated fats, even though we told them, please eat the healthy fats, and they had like a higher percentage of the bad fat, same results. We did not see any other influence on LDL cholesterol. That was our hypothesis, that, if they were eating a lot of saturated fats, maybe we saw something, other results in the LDL, but we did not see that. So it was kind of interesting. Yep.
Importantly, look look at ApoB in that
Yes,
population?
we are going to measure that. Yeah. Thank you.
So I think maybe I can add a little question here, because I think it's really the question now. We have these really encouraging data. There's a limitation about the length. But then we really need to consider, are there any really both concrete or hypothetical downsides of having this diet? Because if it really have this effect that they both lose weight, they improve their diabetes control and an NAFLD, then it's probably something that we should have among what we can discuss with our patients. So Camilla, what are really the downside from your point of view, and what would you advise basically going forward here?
Okay, thank you. So if it was my patient, I would ask the patient, what do you want for maybe the first time, right? Because now it's, you got to do this. But wouldn't it be amazing if you could give the power back to the patients and ask them, hey, we've got the Mediterranean diet. It's evidence-based. It's good. We've got the low-fat diet. It still works. We saw that. They improved also, but not as much. And we got the low-carb, high-fat diet. So, hey, what would fit into your life? Because we know that one size doesn't fit all. And I really believe that if we could engage patients more and they could take, power of their own situation, I think we would kind of maybe move a little forward.
Okay, very good. Thank you. And about that, with the implementing significance, we have the question for you, Scott. So it's a tough one. What is the significance of the Pemvidutide study? I think, you try to go, and so I think in terms of when will this really change clinical practice? How far are you from implementation, et cetera?
Right. So we are currently completing an advanced phase 1 study in patients who have fatty liver disease. We're assessing the reduction in liver fat non-invasively, but it's also a weight loss study. So we're actively following patients' weights over the 12 weeks, and we have an extension to that study that'll take treatment out to 24 weeks. And that'll be extremely important because that'll tell us about the weight loss and also the liver fat reduction over the long term. More importantly, we've launched a large phase 2 study in obesity, very similar to some of the studies that you've seen in the press recently with semaglutide, also known as Wegovy, and tirzepatide, also known as Mounjaro. And then after the completion of these trials, we expect to go readily into phase 3. These trials enroll very quickly. They're conducted over approximately 24 weeks to a year, so we could be in advanced development in a program leading to approval in the very near future.
Thanks a lot. And then I think that's all time we have for now. So thank you very much for joining. Thank you very much for the questions. Thank you very much for you for sharing and discussing your own data. If you have more questions, then please contact Michael Kessler from the EASL ILC comp teams, and we will be available. Thank you very much.